Talking back about varicose veins, it's common. You see it a lot. Most of these patients will probably be obese. They have venous insufficiency. It can be genetics. So once they start to have it on a chronic basis, what will happen is that all this little leakage of the blood in your dermis will start to make the dermis and the subcutaneous tissue thickened. This is what we call lipodermatosclerosis. So it will feel woody. And with the same time, when you get leakage of blood in the skin, what we have in our blood is basically the hemoglobin and the iron. So what the iron would do, if you have it outside, it will rust. So in our bodies, this rusting of the color will be brown. And this is why you see these patients with all these, initially could be looking like just reddish patches, and later on will turn brown. And this brown you cannot really get rid of. It mostly stays in. But over time, if you don't treat it, you don't put them in compression, you don't allow them to have leg elevation, then it starts to get more and more thickened and more worse. So it's always a good thing to always make sure you have maybe a good Doppler or do an ABI to make sure that they have a good circulation. If they do, put them in compression, encourage them to wear their stockings first thing in the morning, and maybe only take it off when they go to sleep or get into a shower. Of course, once they have the aggravated dermatitis, you need to treat it with some topical steroids. So for dermatitis, it's a big name. It's just meaning eczema. But what is it from? Is it something from inside, like atopic dermatitis? Is it related to what I showed you right now, stasis dermatitis? Or is it something from outside? So something that they're using or they're putting on and causing them contact dermatitis. So definitely you need to identify what is causing the dermatitis, and you can treat it accordingly. If you start to see patients who are having this cracked skin, once you see crusting on the skin, it gives you an indication this can be related to infection. So it's always very easy just to take a swab, send it for culture and sensitivity, and you can treat them according to what you would get back. I always encourage you, if you see any growth of staph or strep or whatever bacteria, use oral antibiotics. When you have a whole big area involved, topical antibiotics like polysporin or fusidin or bactroban will not really do the job for you. So don't be kind of hesitant of going for about 10 days of antibiotics in this case. If you have somebody with eczematous dermatitis from atopic or allergic contact or irritant contact, always remember these patients are itchy. So it's always good to give them oral antihistamines to help with the itch. I would like you, please, 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 do not use topical antihistamine and topical analgesics. These are always on over-the-counter. They have Benadryl cream, and they have all these Lanacane and all these cane kind of a family of anesthetic and allergesic over-the-counter. These are big allergens. Like I do patch testing in my office, and we see lots of allergies to these products. So don't get your patient to use them. If they want to use something, just a bland emollient, bland cream, and then you can give them oral antihistamine if you need to. Of course, the treatment will be with topical corticosteroid or the new calcineurin inhibitors that we have in the market, like tacrolimus and pimecrolimus. And you would have severe cases like the cases I showed you with a severe allergic contact dermatitis. In this case, don't imagine that 1% hydrocortisone or even betamethasone valerate will take them far. In this case, you will have to put them on systemic steroid. And always remember, when you're treating somebody, let's say with an allergic contact dermatitis, your most common one is, let's say, poison ivy. Don't just give them the 5 days course of steroids. And this is a reaction that takes days and weeks to go away. So you don't imagine you're going to take it away with just 5 days. It's not like when you're treating, upper respiratory problem. So usually in these cases, you will have to wean them off over 2 to 3 weeks with a steroid. And what we sometimes do for our patients is that if we feel like, you give them a steroid, after they finish it, it comes back again. Sometimes we send them for phototherapy, so they can have UVB phototherapy, narrow band or broad band. Or sometimes we have to go for some immune modulator It's not unlikely that we have severe patients that we have to put on cyclosporin or methotrexate to keep their eczema under control. So these will be the patients that we will encourage you to refer to us. So when we talk about other preventable skin disorder, this is something that you're probably going to see also a lot in the hospital, especially in the summertime, or maybe if you're seeing patients in retirement and nursing home, is what we call miliaria rubra, or what is known as heat rash or prickly heat. So with the sweating, basically all these pores, where you have the ducts opening for the sweat glands, becomes inflamed. They become inflamed, and you end up having all these kind of tiny red, very, very itchy papules. Very common area to have them will be on the chest and on the back. Some patients can have it all over, like arms and legs, but this is a very characteristic area for them, and they will be very, very itchy. So in this case, what you need to do is basically cooling their skin down. So having a fan in the room, encouraging them to have some showers with a little bit of cold water or lukewarm water, gets them to wear clothes that will be breathing, like kind of loose-fitting cotton clothing. And you can always add some hydrocortisone to help, 1% hydrocortisone or half-strength betamethasone valerate. It always helps to add some menthol to it. So I usually add like 0.25% or 0.5% menthol, or sometimes even camphor as well, just to kind of cool the skin down. Another one that you see a lot, we didn't used to see it until this year. I don't know if we're having some kind of another epidemic of scabies, which usually happen every 20 to 25 years. So I think we're on this kind of cycle now. That you see scabies in elderly, and sometimes it can be very tricky because, first of all, when you have it in a nursing home or a retirement home, that's a big disaster because the contact is what causes the scabies to spread. So when you treat, you probably will have to treat every single contact. So not just the patient or whoever with them, if they're sharing rooms or their nursing staff, but everybody who's in contact with them as well as their families. And always remember the families. Because we had one patient who kept on coming back. They treat her, she gets better. A few months later, she comes back with the same problem. And it turned out to be that her husband was the guy who had the scabies. He would come and visit her, sit with her. She was the one getting the treatment. He wasn't getting any treatment, and it kept on going on. So it's something that's very easy to treat if you just keep in mind that you have to treat them, you have to repeat your treatment in a week, and you have to wash everything that they've been wearing. I always recommend them, especially in winter time, if they have big coats or big blankets or covers that they can't wash, to put it in a big garbage bag, really close it tight, and leave it aside for about 7 to 10 days. This is enough to get rid of the mite, because the mite doesn't survive more than 2 to 3 days, but it will just clean it and you don't have to wash it. You do the treatment after a week, because when we treat scabies, like let's say with your Next 5% or Qualada lotion, which is basically your topical permethrin, you're basically killing the adult mite, but you're not killing the eggs. So these mites usually have eggs burrowed under the skin. Once they hatch, like the eggs, it's not ovicidal, the treatment. So that's why we do the treatment after a week. We make sure we do that, okay? Another preventable skin disorder, and we see it a lot, is decubitus ulcers. And pressure ulcers, are very common in people who are debilitated. They're maybe on a wheelchair all the time, or they have some neurologic problem that you cannot really move them from the bed. We have to make sure that we get them either like air mattress, or if they're sitting on a wheelchair, you can order Roho cushion. And basically, these are almost like a donut-shaped cushions. They have air inside, so it decreases the pressure, and this way it will relieve the tension. You always have to make sure that if you have, let's say, a patient who's bedridden, that when whoever giving their care, make sure that these sheets are very well stretched. Any tiny kind of wrinkle under the skin, imagine you have pressure in a linear way or whatever for hours until this patient they're able to kind of move them around. From this pressure, this is where you're going to get it. So they have really to have a good fitted sheets on their beds. And of course, the one thing that can make it worse is incontinence. And we know that most of these patients will be in diapers. So again, keeping them dry and clean makes a very big difference in preventing these kind of ulcers. So if we go back and we talk about what do you usually see in patients, elderly, like with skin problems. So basically sun damage. So many patients will come in and they have all these spots on their face and they're worried about it. They have pruritus. We talked about dryness. Some patients become compulsive excoriators. And this is not uncommon. The patient is just sitting there. They might have a little bit of a dementia. What they do is that they just keep on feeling their skin. And once you have like a seborrheic keratosis, like an age spot or some roughness, what they start to do is that they will start to pick. And they get into the picking habit. And they keep on excoriating their skin. You see a lot of intertrigo infection, and I'm going to go over this quickly for you. So atrophy, this is not uncommon. And sometimes I get these patients coming to my office when it's really like severe, wondering if they have some kind of a hematologic disorder. And sometimes these patients will come in and they've already been seen by a hematologist and had all kind of blood tests to rule out that they have some kind of bleeding disorder. And basically what's happening is that you're getting purpura in the skin, what we call Bateman purpura. So what happened was, and we remember we talked about age, that it can decrease your collagen and decrease your subcutaneous fat. So what happened is that this collagen is basically your mortar that's holding everything up. Once you lose it, these blood vessels start to dilate because they're weakened. There is nothing to hold it in place. They start to leak some blood, and you start to have the purpura. And the purpura starts red, maybe a little bit purplish, and stays like that for weeks. And when it goes away, you're going to end up, remember, you have iron, so it will end up looking brown. So most people, these people would come in and they say, I'm bruising, but I didn't have anything like touching me, nothing fall on my hand, and look at me, there is something is wrong with me. But actually it's just from sun damage. These people probably had lots and lots of sun exposure when they were young. They might have been having also reasons for them to have this, like they're on baby aspirin, they're on anticoagulant, they're on corticosteroid for whatever reason, oral prednisone for maybe arthritis or colitis or something like that. So in this case, if you're really worried, just do an INR. Okay, just make sure it's not a problem. But other than that, you don't really have to do anything, and we don't have a treatment for it. Dermatohiliosis is basically meaning sun damage. So you can see solar elastosis, which is this first page, first photo here, where you can get this kind of yellowish, thickened plaques. Like the skin looks really mallow. It doesn't have this nice glowing look to it anymore. And this is basically from collagen degradation from the sun. Or you can have what we call poikiloderma of Civet. And this was, Civet was a dermatologist who described it. And you always see it in patients, doesn't have to be elderly. People who like to do outdoor sports and they're always out and they're not using sunscreen, you're always going to see it on the sides of their neck. And when it starts to get worse, it will be on their V-chest. The way you can tell, it looks like this kind of mottled hyper and hypopigmentation with some telangiectasia. And you can tell when you look at them that the area under their chin is clear because basically the chin is shading this area. So then you don't get the sun damage there. Favre-Racouchot syndrome, this is more of a cosmetic problem or a nuisance for patients. It's not a real disease. So these patients, again, from all the sun damage, they get this huge, big open comedones. So basically they get these blocked pores, and you can see multiple comedones in almost like a plaque fashion. And it's usually around the eyes, around the nose. Sometimes they will have it on their temples. And you can probably treat it for them with a topical retinoid. It would help to get rid of these comedones. So one big problem when I get it in my office and I have with some of the consults just one word, and would tell me pruritus or itch, and that's it, and nothing after. then this is one of my nightmares and all dermatologists' nightmares, because we have to figure out why, and especially if your patient doesn't have any rash. If they have a rash, we try to sort it out. But if they don't have a rash, then you have to look for systemic cause of this itch. So basically, first thing to do, we always ask, and this is why we always ask for a drug list, did you start any new medications? Okay? So, and by new medication, it could be over the last 6 months maybe, okay? But you have to kind of link their symptoms to anything that you changed. And you just have to be aware that sometimes just changing from a brand drug to a generic drug, it can cause a problem. Unfortunately, we don't have our generic drugs tested, so sometimes they can be just one ingredient in it that can be different from the brand name drug, and this can cause problem for your patients. So always, it's a little detail, but it can make a big difference for your hunting about this pruritus. The one that we know are a big culprit are NSAIDs, all these pain medications that many people are on, or your opiates. Many of the diuretics are really high on the list, and also your ACE inhibitors. The second one you want to look for is malignancy. And the main one is basically lymphoma. Just the other day, one of my partners in the office had a young lady, she was only 37, all of a sudden had severe pruritus. She was just coming with leg edema, she was obese, she has varicose veins, and she was working her up for all the systemic problems. The second time she came in, she had one limb hugely swollen from thigh down for, like you think, what's going on? And she felt she couldn't feel any lymph nodes, so she ordered a CT scan, and well enough, this lady had lymphoma. And basically, it was the effect of the pressure of lymph nodes in there. So malignancy is one of the reasons for you to think about pruritus. Thyroid disease is a big one. Most of the patients have problems with the thyroid hormone level. So it can be either hypothyroidism or hyperthyroidism to cause the pruritus. Anemia is another cause, and especially iron deficiency anemia. Of course, we all know about liver and renal problems causing pruritus. And polycythemia rubra vera, when you have a patient who always has the pruritus when they take a hot shower, this can be an indication that they might have that. So again, for pruritus without dermatitis, you have to order a big panel of blood tests and investigation to find out why they have it. So usually what I would do, first of all, you have a good history and you go into real details about every single thing that they probably had different. And then you do a good physical exam involving checking for lymph nodes. Then what I will order a CBC with differential, I order a creatinine, and LFTs, TSH, ferritin level, and I usually order a serum protein electrophoresis. And I order a chest X-ray, because sometimes they don't have symptoms, and you'll be surprised. We kind of got on patients with lung cancer without having any symptoms whatsoever, and we will be doing chest X-ray for other things. So it's not a harmful thing, and it's a cheap test to do, but it will be part of your workout when you're doing pruritus. I told you about compulsive excoriations. The clue for you to know, these patients are coming in with these big excoriated, bleeding, crusted, infected lesions. They will only do it where they can reach. So you're always going to find it. It can be on their face. Some people are so compulsive about picking their face. Maybe they had acne in the past, they had some scars in the past, and all of a sudden they start to pick at it. It's usually on their chest, arms, legs, belly. The part that you're not going to see it, they will have it on the upper shoulder, but middle back, it will be nice and clear. And there is nothing, because they cannot reach. And this will be a clue for you to figure out it can be that. The other thing is, it will be almost like geometric shape. Like when you get all these looking rectangular and triangular and linear and so on, our body doesn't make anything from inside this way. So you think it's something from outside, and the patient is usually the one doing it. The problem is, if you have a patient who doesn't have an insight that they're doing it, then this gets really a problem to try to convince them that they are the one causing this problem. But if they know that they're picking it, it's easy to kind of educate them. You tell them, try not to pick. What I tell my patients, when you're going to bed, you wear cotton gloves in your hands. You can get them from the dollar store or from the pharmacy, white cotton gloves, put them to bed. Because most people scratch without realizing during their sleep. They wake in the morning and they have all this blood on their sheets and they wonder where is this coming from. Okay? During the day, I tell them, keep your hands busy. Because they will be scratching when they're on the phone, when they're watching TV, when they're, not really doing something. So I say, get some squishy balls, the rubber balls that you can buy from the dollar store, and keep it in your hands. Because for you to itch, what you're going to do, you're going to put it down to start scratching. Then you're going to remind yourself, I'm not going to do that. And people with insight, they actually do very well. And you see them next time, and they're great. But when you see them for the first time with all these crusted lesions, remember, when you have crust, it means infection. So you have to put them on oral antibiotic for at least a couple of weeks to get this down. Gives them maybe a mild steroid like betamazone valeriate 0.1%. Gives them an ointment base so it will stay there. And encourage them to cover it if they can. It's very easy to do it when you're covering with a dressing. Another one that you see a lot from rubbing and scratching, if they don't excoriate and they don't break their skin open, they will get what we call lichen simplex chronicus. This is basically what's happening is that you're getting accumulation of layers of epidermal cells. So it becomes really thickened plaques and they are very itchy. And it can happen anywhere. It can happen on legs, and this is a very common area like shins and legs. You see it a lot. You can see it on their hands. This is a very common area too because many people have hand dermatitis, and if it's not well addressed, they keep on rubbing and scratching and itching. And it can happen also in the genital area. So many women, and especially elderly, because they have dry kind of groin and perineum, they get lots and lots of itch in there. And then they start scratching, and you end up having lichen simplex chronicus over there. So what you usually need to do, first of all, address the itch, address the pruritus. So give them an oral antihistamine. The second thing is that in this case, you need to really use a potent steroid. So your 1% hydrocortisone or Elocom or Disonide and so on will not do it. You have to go for like a potent steroid like clobetasol, halobetazol, one of these like, strong ones. You don't have to use it for long. I usually tell patients to use it for a couple of weeks maximum and then come down and maybe use their hydrocortisone again. But you really need to hit it hard to get most of this inflammation down and take all this thickness of the skin to get back to your normal epidermis. So don't be afraid of using potent steroid in this case, even on vulvar area, as long as it is for a short period of time. Prurigo nodularis, that's another picture of itch where people are scratching, but instead of scratching on a big area, they just pick in a small area. So they end up having these nodules that are coming from the dermis. They can be crusty, they may not be, but they're very, very itchy. The best thing for this one is that you give them a potent steroid again, and you ask them to cover it. So what I tell my patients to do, I tell them go to the pharmacy and you buy a dressing called the Coban dressing. The Coban dressing is an elastic, sticky dressing. It's not easy to move around. So if they're sleeping and they're trying to scratch or rub it, it's not going to move around. It gets really sticky on their arms and legs. This is very easy to do, of course, on extremities, not on the body. If they keep it on for a good period of time, most of these lesions will heal on their own because they're not picking at them. The other thing that we sometimes do, like in my office, I'm sometimes treated with cryotherapy. Liquid nitrogen can just basically take all these down. Or you can inject it with steroid or use a potent steroid on it. Some patients, when they have it all over their body, it's very kind of unpractical to treat each one. Then in this case, we send them for phototherapy, and UVB is a good treatment for them. And thalidomide is something that you can use, especially in elderly, because you're not worried about pregnancy and teratogenic effect. For very severe cases, we do that. So again, it's another one that you might, if you're kind of scratching your head, what else I'm going to do? It's a good referral to send over to us and get us to scratch our head. One you see a lot is intertrigo, and this usually you're going to see a lot in the summertime. Heat, sweat, friction, So it's usually under the breast for women, in the groin area. And the problem is that you can get colonization. So these patients can have candida, which is the most common. And the way for you to know is these satellite lesions. So these tiny, small pustules, sometimes you don't actually appreciate the white head. But when you see it, all these small white macules everywhere, it tells you this is probably a yeast infection on top. They can have, of course, fungal infection or bacterial infection. And sometimes when you treat it, let's say you use your clotrimazole or you use Lamisil or whatever antifungal, anti-yeast cream and doesn't go away, then you might think it might be something else. So it could be that these patients have psoriasis. And psoriasis, when it gets in the flexures, it doesn't look scaly as what you see on elbows and knees. It can be just very well-defined red patches. It could also be some kind of a dermatitis, like especially if they really feel it itchy and it's spreading, and you don't see the satellite lesions of yeast, you think they might have an irritant contact dermatitis just from the rubbing and maybe using, soap or something there. Or it could be that they're putting something to kind of calm it down, and the creams that they're using, they're becoming allergic to it. So that could be another reason. Some patients also will have seborrheic dermatitis, and it's not uncommon to see severe seborrheic dermatitis in elderly, exactly the same way that you see it in kids with cradle cap. But with elderly, it's usually in their flexures. So the easiest solution, and I know you all do it, is just adding a little bit of hydrocortisone to your creams. You can always put like 1% hydrocortisone powder to your clotrimazole cream, or you can combine it with anything else. I like to use Ketoderm if the clotrimazole doesn't do it much, because Ketoderm has a wider kind of big coverage. You can add it to Lamisil if you want. But it's just, if it doesn't really respond, again, that's another reason for us to see patients. And again, one thing I will bring up, please, when you see something like that, check the patient. Don't rely on what they're telling you. I know after a while we get tired of it's the same problem and we try to give them a prescription and let them go. Just take a look and check them. I just had a patient not long ago who came in with this kind of recalcitrant rash, wasn't going away for a year and a half. She's been in a nursing home. They've been putting all kind of antifungal, antibacterial cream you can imagine, and nothing is helping. They started to use steroids. They went up to clobetasol, and it was under her breast, and only one breast. When you see something just unilateral, kind of try to think, this may not be, just a regular eczema or regular yeast infection. And this lady, unfortunately, she had breast cancer. The problem is it was getting out, so it was direct extension. She had a big erosion, and the erosion was just crusting and it was red. But if anybody felt it, it was a big indurated plaque under her breast. So I know that sometimes we get busy, and when we have recurrent problem in the same patient, we just, we said, okay, try this, maybe try that. Again, just kind of reconsider another diagnosis when what you're working on doesn't really respond to your plan. It might be something different happening there. Okay. Frozen. My computer doesn't respond. Oh, here we go. Another form of candida infection, you see it a lot, is this what we call angular cheilitis. So at the angles of the mouth, these patients will have the cracking, fissuring, maybe a white film. And this is basically for when you get an elderly patient, their denture, maybe get a little bit looser, and they have more skin there, so they have more skin folds. And especially when they go to bed, they have a little bit of saliva on their angles of the mouth, then this is a good media for candida. So again, you can basically treat it as if you're treating it in any other intertrigo. 1% hydrocortisone and clotrimazole cream. You might get them to use Vaseline at bedtime just to have a barrier there. So candidiasis in general, in normal immunity, you basically treat it with topical therapy. And we have so many products available: nystatin, ketoconazole, meconazole, and clotrimazole. But when it's really recalcitrant or it's widespread and you have an immunocompromised patient, in this case you might need to go for oral antifungal, so like diflucan. It's very effective, and they don't have to go for a big course. You can just do it in a very small pulsed kind of therapy. Herpes zoster is very, very common. You see it a lot. And thankfully now we have a vaccine. And we encourage our patients to take their vaccine for shingles. As dermatologists nowadays, because we have new treatment for psoriasis, which is biologics, and because it's an immunosuppressant, and we worry about the risk of infection, all our patients, no matter what age they are, we get them to take their shingles vaccine before we start them on treatment. So now the recommendations in Canada is to give shingles vaccine at age 50 or above. Used to be 55. Now it's at 50. And why we're doing it? Because some people say, so what if they get a little bit of shingles? Yeah, it's going to be a pain for a couple of weeks. The problem is the post-herpetic neuralgia. Okay? Some people can be miserable. And some people commit suicide from the post-herpetic neuralgia. It can be that extreme from the pain and the ache. So you can drop about 2/3 of this post-herpetic neuralgia by vaccinating your patients. Okay? It decreases the incidence of herpes zoster infection by about half. So it's something that you keep in mind to give to your patients. The one thing that I always bring up, you cannot have bilateral shingles. I haven't seen it. It's very rare. So it's not uncommon where I get patients coming in and say, I had shingles 3 times. I know right away they never had shingles. You have shingles once and you get immunity to it, maybe twice if you're really immunocompromised. But when you have shingles, like I have patients say, I had shingles, and where was it? He said, it was in my forehead and in my arm and in my belly. Okay, that doesn't make any sense. You have to have shingles in a dermatomal kind of distribution. So yes, they can have it following the trigeminal nerve. They can have it with the intercostal nerves. But you cannot have shingles different ways. If you're seeing blisters and you're thinking this could be shingles, it could be chickenpox. Yes, they can have chickenpox if they never had chickenpox in the past. So the best way, just take a culture. You can get it from the lab. We have these small tubes for viral culture. Just take a swab and send it to the lab to identify if this was virus or not. So it's an easy thing to do, but I always kind of remind and encourage you to go for the herpes zoster vaccine for your patients. Some of the serious skin problems in elderly are immunobolus disorders, and I'm sure who of you like work in retirement or nursing home probably saw this a lot. It will usually happen in elderly for the bullous pemphigoid. It's the most common autoimmune disorder in the elderly. These patients can initially start having what looks like hives, like urticarial plaques, very, very itchy. But you know, with urticaria, it's the only skin condition that doesn't last more than a day. So if somebody has real hives, it will come and go. They might have a new crop every day, and they say it's been there for weeks. But if you ask them about the solitary lesion, if you say, if I mark this today, you're going to have it in 2 days, they say no, it's going to be gone by tonight or tomorrow morning. But these patients will have these urticarial hives in place, and then later on, they will start to have blisters. And the characteristic thing about their blisters are very tense. I don't know if you can appreciate it from the picture, but you can see it's like a tent. It's really solid, tense kind of a blister. Of course, when these blisters break, they end up having some erosions there. And bullous pemphigoid, it can be controlled. The only problem is that they don't want them to get into serious infection with these open kind of erosions. And then the other thing that can increase the risk of death or bad prognosis is just the medication that we're using as immunosuppressant. So definitely when you see somebody like that, it's a referral for dermatology, and right away. The other one that's not like, you know, that easy to treat or has more morbidity is pemphigus vulgaris. And these patients, it's hardly that you're going to find an intact blister on them. So on the other way around, their blisters are usually flaccid, and they end up having huge erosions. The other thing with pemphigus vulgaris, most of these patients will have mucous membrane involvement. So they can have it in their mouth, or they can have it in their genital area. Sometimes they can even have it in their esophagus, a conjunctiva. So these are emergency. And these patients, sometimes we need to hospitalize them. We have to deal with other services, ophthalmology, ENT, and so on, to make sure they don't have any erosions anywhere else. So again, they have to be on immunosuppressants. So this is another referral for dermatology. And please, when you see something like that, don't just put it on a paper and send it by fax. Get your nurse or yourself on the phone and talk to whoever is on call, or if you know a friend dermatologist in the city or somebody, because these are patients that need to be seen right away. You can't imagine, I'm talking about Ottawa, I don't know how it's like everywhere else, but the shortage that we have, our waiting list can be from 2 to 6 months. And if we don't have a good referral telling us what it is, the triaging becomes a problem. So if you see something like that, don't just rely on sending a fax. Get on the phone, talk to us, and we'll be happy to see your patients fast. The last thing I'm going to talk about are the tumors. So you see lots of the common benign tumors like seborrheic keratosis. They can be any size or shape. They can be any colors. They can be skin colors. They can be whitish, beige, grayish, dark brown. But the main thing is that they are all epidermal cells. So you can feel like you can just pick them, you can flick them off. They're not like a dermis, like a nevus. Fibroepithelial papillomas, like skin tags, you see it a lot. Lentigo, so basically all these freckles that you see, either senile lentigines, which is from age, or solar ones that are from the sun. What I always tell my patients, when you have a lesion like that, that's totally fine. It's very well defined, uniform, one color all through. I worry about it if it starts to change. So if you start to have a dark pigment there, or the borders start to become irregular. It's not uncommon for lentigines to get larger over time, that's okay. But if they start to change in the actual shape, border, or color, or they start to become raised, they've always been flat, and all of a sudden they have a papule in there, you worry about lentigo maligna melanoma in this case. Keratoacanthoma can be a little bit tricky because it can look exactly like a squamous cell. The probably the clue, if it's following the textbooks, is growing fast. So it will be a small pimple or bump, as the patient would say. They say, I have something look like a mosquito bite, and within a few weeks, it tripled or quadrupled the size. So that's one thing that will tell you it's a keratoacanthoma, this kind of a dome shape, and you have this keratotic center in the middle. Actinic keratosis, you see a lot. Most of these lesions can resolve on their own, but about 5% can turn into squamous cell. So this is why we try to treat it. Sometimes you can have a heaped up one like this one, what we call cutaneous horn. Cutaneous horn does not have to be on just actinic keratosis. It can be on anything. It can be on a wart, on seborrheic keratosis, on a basal cell, on a squamous cell cancer. So whenever we see a horn like this one, we usually have to cut it out because we don't know what's underneath. So we have to send it for pathology. Squamous cell carcinoma, you can see it a lot. The one thing that you have to worry about, if it's an area where it can spread hematogenous, so like lips is a very serious part of the body to be involved, or where you have lines of fusion, so like around temples, around here. So again, it can be growing rapidly or slowly, but it will look as if you have an ulcer or a sore that keeps on crusting and not healing. You can also have the basal cell carcinoma. That's the most common type of skin cancer that we see. We usually say somebody with a very fair skin, had lots of sunburn, blistering burn, will at least have one through their lifetime. The only problem is that when we ignore it. So when you have a lesion that doesn't go away, sometimes it can look like, if you look at this one, you probably think, oh, maybe this is an eczema patch. You know, I had a patient coming in with 5 of these lesions on his back for 3 years. His physician kept on treating with all kinds of creams, wasn't going away. They were all superficial multicentric basal cell carcinoma. So again, when you have something that's persistent, doesn't go away, maybe just kind of rethink again your diagnosis. And then melanoma is the most serious type of skin cancer. We always try to educate our patients about the ABCD for their nevi. We always tell them if something changes, please contact your family doctor and don't let it go. Lentigo malignant melanoma, these are the ones that come from the sun lentigines I showed you before. So they start to change, they get darker, they have a regular border, they might be a little bit more palpable. Then these are the ones that we worry about because these ones they can expand and sometimes it's hard to get margins on these lesions. Acral lentiginous melanoma, I think this is one of the most serious ones because they go most of the time unrecognized and untreated, and many of these patients will end up having amputation of their toes or fingers. And that's the end of my talk. Thank you very much.